here we are moving on, and we are almost getting ready to get into the EKGs. But first, before we dig into that, we need to make sure we take all of the anatomy and the basic physiology and put it into pathology. So when we take a look at the pathology of the heart, we want to take a look at what could happen that could cause those ailments, and then we're now looking at testing. So what are some of the basic diagnostic tests? Obviously, as we read EKGs, our end of this class is being able to run your own stress test, run your own GXT. So what we're going to do today is go over some of these key objectives. So probability for coronary artery disease that we're looking at assessing, so pre-test probability, what is the right test based on your pre-test screening, and then being able to evaluate all aspects of the exercise stress test, type of test selection, we'll go over different tests, who can run the test, the staffing, modalities, other cardiovascular assessments. We'll talk a little bit about imaging. I think imaging is an important thing because it is a role as exercise physiologist could play. And then take a look at some of the other testing that the patient could go through with a physician, an angiogram and some of the other scans, PTCI, we'll go into CABG and open heart surgery as well. Okay, so when we think about what we've gone through in the last couple of chapters about structure and function and physiology, we want to now look at how heart disease happens, right? So when you're, as an exercise physiologist, taking in a client for the first time, we're looking at their medical history, giving them a physical exam, and following the recommendations from the American College of Cardiology, that's one big one, right, the ACC, and the AHA, the American Heart Association. These organizations are really the kind of the guru organizations that we follow in the world of cardiology. So as an exercise physiologist, even though we, again, know ACSM has great stuff, we're going to be going into ACC and AHA. They will outline non-invasive testing as well as invasive testing. So obviously we're only doing the non-invasive stress test, but I want to make sure you're aware of all of the others as well. We'll go over evidence-based data with providing information, costs, all of those things. So when you look at recommendations, we call those evident recommendations. This was in, I have an article, maybe in my other section of my other class, that this was actually one of the things that you had to read and do a summary on. Not for this class, but anyways, it looks at 4 classes, class 1, 2A, 2B, and 3, and this classification tells you the intervention is very useful. The next one, 2A, is weight of evidence and opinion is in favor. It should be useful, pretty effective. 2B is it's well established, based more on evidence and opinion, so not as grounded in the literature, but still decent. And then 3 says, this may not be useful, and if anything, could be a little harmful. Then with that, there's letters, A, B, and C. So this is what type of research has been done. So if it's an A-level evidence, it's been what we call multiple randomized trials. So subjects, randomized, and really gives a really rich, robust data from that you can extract from a population and be able to apply it. B is from a single randomized trial or non-randomized trials. So this is when you're looking at the research article and you're looking at the methods of a research article. Again, all of this evidence-based information is what drives practice, medicine practice. And then C, it's case studies, kind of standard of care. This might all be a little bit too much, but AAA and ACC has a really good listing of how the pecking order goes with what we should be doing and when. So when you look at the pretest probability of coronary artery disease, or looking at pretest probability for basic heart disease, oftentimes when you talk about angina, right, likelihood that chest pain is mimicking cardiac pain, we want to take a look at some other factors. So I identify the patient's gender, male, female, look at their age, and then we're going to take a look at the table. And that table is going to help determine what we call the likelihood of test. And then the next step, once we figure out the likelihood, is to go into the assessment process. So when you take a look at the table, so appropriate candidates, these are patients of intermediate risk based on age, gender, and symptoms. Lack of repolarization, which we haven't talked about repolarization yet, abnormality associated with what we know as a right bundle branch block. So a right bundle branch block, is something we're going to look at and we'll understand why this is in in the consideration table. Or 1 millimeter of ST segment depression that is not due to digoxin, and there's a lot of information there. Digoxin is a medicine, a cardiac medicine, and that digoxin medicine can cause ST segment. It does usually cause ST segment changes. Inappropriate candidates would be people of low risk, ischemic. Remember, the word ischemic means lack of blood flow. So people who have symptoms, but they're more at the lower end, pre-existing repolarization abnormality due to a left bundle branch block, so right, left, we'll talk about those later, and greater than 1 millimeter. Pre-excitement syndrome, called Wolff-Parkinson's-White, patients unable to exercise or cannot maintain stress, so this would be people who get less than 85% of their predicted heart rate, or taking the double product, and the double product is when you're looking at the systolic volume and their heart rate, and then patients who have angina who have undergone a previous intervention, revascularization. So revascularization would be open heart surgery or angioplasty, balloon, stenting is a revascularization. Okay, so diagnostic accuracy of a test. Best if it's a low risk, low cost to the patient, right? So when you're looking again at the pecking order of how do they determine, do I have a stress test? Do I go and right to the cath lab? So there's a thing called a decision tree. We don't need to know the decision tree. I like to help patients understand when they ask questions, why did I have this test but my, whatever, coworker had another test. So these are medical standards based on who they are and risk. So these decisions in the decision tree are made by the physician, medical records, consent, instructions, what mode of testing, what protocol interpretation. It's not just a guess. So picking how they're going to diagnose these symptoms, what kind of testing they're going to use, is really well written out, and we need to follow. And obviously we're not just going to jump everyone into the cath lab, which gives us really good results. It's very expensive. If we can, for a fraction of the price, get similar information that we need just on an exercise stress test. So we know, and you all know, that the purpose of this class is to be able to run your own stress test, right? So GXT. In order to do that, we need to get into the EKGs. But before we do, we know that why? What is the benefit of a stress test, right? They do stress tests in doctor's offices, in the emergency room, right? They're done in so many different environments. We do them in the exercise physiology lab on campus. So to diagnose cardiovascular disease, to be able to look at risk factors for CAD, coronary artery disease, we can assess fitness level. I love it when someone has a stress test before I write them a program, because now I know exactly their workloads. I know their angina threshold. I'm able to really understand their fitness level. Really important, it can help us with dyspnea, right? The word dyspnea is shortness of breath. So it says determine the pathology of the dyspnea. So what is triggering a shortness of breath? Is there, again, a threshold for what's causing some pulmonary problems? So very good information on dyspnea. It can assess the response of exercise training and medical therapy. What this bullet means is it is a common exercise testing is often done in duration, right? So they may give someone a new medicine and then wait a few months and then run a stress test again. So this way they can reassess to see if the therapy, the medicine is working. So you kind of put the person on the program, on the regiment, and then we reevaluate them again. For a lot of times when you run a stress test, it could just be in the doctor's office where they want to be able to return them back into work, especially if it's a work that has a kind of physical ability, a truck driver, factory workers, first responders. So they would have to pass a stress test before they're clear to go back to work. Sometimes if they're not, they end up on disability. So a lot of stress testing is done for both work and workers' compensation. And then obviously the big one is to look at the severity. How bad is the disease? Is it getting worse? What type of treatment needs to be done? What's the prognosis? All of those kind of basic things. So from one test that you and I, as an exercise physiologist, can run, there's a lot of incredible medical information we can get out of the GXT, the stress test. This is a variety of different exercise test protocols, and depending on what other classes you've had previous to this, my guess is you're used to the Bruce protocol, right? The Bruce protocol is what we use for apparently healthy individuals. It's a pretty aggressive test. The workloads are going to increase every 3 minutes, and it begins at 5 mets, and then it's going to increase. Right? 5 mets is a lot of mets to start at for someone who's deconditioned. So by just looking at this slide, you realize that a Bruce protocol is probably not what we're going to be doing using a lot of elderly people. So this table doesn't go over all the different types of protocols. Depending on where somebody works, there's different protocols that progress. Instead of starting at 5 minutes, they start at a lower and they ramp up at a different intensity. So I want you to know that the protocol in which we're going to talk about is going to be the Bruce. But I want you to realize that what protocol you actually do in your internship and in real life is going to depend on, what ability, what physiological ability we believe that client can do. Who can run a stress test? And this is interesting because there seems to be a lot of the population is a little skeptical about this, but under physician supervision, any of the following professionals can conduct a GXT, a treadmill stress test. Clinical exercise physiologist, so that word clinical oftentimes is denoting a master's level, not always, but commonly. Physical therapists, medical technologists, nurses, those are your common ones. So when we talk about under supervision, usually it just means that there's a physician around. If you needed one, they're there. They're commonly not with you as you're at the computer. So we just want to make sure that there's someone around. If we need help, we can get help. So lots of times in a cardiac rehab, it's either going to be the exercise, the EP, the CEP or EP, whatever, clinical exercise physiologist, or the nurse. The risk of testing, right, the risk that may result in either someone having a heart attack, an MI, or dying is 1 in 2,500. Okay, so 1 in 2,500 tests, so pretty low risk. There's things called absolute and relative contraindications. So you will know before testing someone what their likelihood is going to be. How high of a risk are they before you go into doing the test, which helps you keep on your toes a little bit more for watching hemodynamic changes, symptomatic stuff that the client, the patient may be complaining of. So again, we have different contraindications we want to be aware of, the relative ones. Absolutely, we're not going to run the test. Relative, we want to be on our toes watching for those. Okay, so test protocol selection. We're going to gather all the data, decide what test we're doing. You can do an exercise test on a treadmill. You can do it on a bike, right? Usually, those are your two common ones. You can do a test that we call a GXT, a treadmill stress test. That's what we commonly talk about in our program and what I'm talking about in this class. A GXT is just the treadmill and the electrodes on the chest. The CPX is a cardiopulmonary stress test. And this is when you combine the breathing apparatus that you have seen on the VO2 max equipment, right, so the metabolic cart that you're breathing in and you're measuring carbon dioxide and oxygen, connected to the EKGs on the chest. That's the CPX. I am not going to pause my lecture and show you these videos. I would encourage you, especially if you're not familiar with the difference between those two tests, is to take some time and watch the YouTube videos. And we can also do it on a bike. Bike tests seem to be a lot more common in Europe than they are in the United States, but we do bike tests here as well. Bikes are great for people who are non-weight bearing, and walking is a problem balance. The nice thing about a treadmill is it's motor driven, so it really can keep people going on it. Anyways, you can also do an armocometer, a seated stepper like a new step. There's lots of ways we can measure. Really, the treadmill is the one you're probably going to see the most of. The CPX, right, like I just mentioned, that's a combination of a VO2 with the EKG. So now you're getting all the cardiac information combined with the pulmonary, also called the CPET. This is open circuit spirometry, metabolic testing. I'm going to tell you more and more cardiac rehab nationwide are doing CPXs. It is tons of data, right? So pulmonary and cardiac, right, for your congestive heart failure patients. So many clinics are moving to CPX testing over just doing the basic treadmill stress testing. So depending on if you're in a clinic getting hours, you're making sure you ask if you can see a CPX or again a CPAP, CPET, a CPAP test as well. This is a lot of data. But this is the data that you have seen when you've gone through your lab test and your lab instrumentation class or some classes with Dr. O, you've done some VO2 max testing. This is all of the data we get when a CPX test is combined with the EKGs, the stress test. So what you see on this screen is obviously the minutes, right? So, increasing workload, what's going to happen with the lung capacity, what's going to happen with the volume of oxygen uptake, what's going to happen with the RER, right? Respiratory exchange ratio, what fuel you're using, what's going to happen with the heart rate. So I'm not going to go into a lot of detail on the CPX because we are not going to do the CPX in this class. We're just focusing right now just on the stress test. That would be the next level of test to do. But I want you to know you take all your VO2 max data, you take all your EKG data, and you put it together, and now that's what we get from the CPX test. Another thing we want to look over or talk briefly about is myocardial perfusion imaging. So these are people who we may run the stress test, but when we take a look at the EKGs, we call it uninterpretable. So we can't interpret what we see. And oftentimes this stems from an innate rhythm that the person's in. Most commonly, the reason why we cannot interpret a stress test or an EKG is because somebody has what we know as a left bundle branch block. We'll talk about those later. A left ventricular hypertrophy, or they're on the medicine digoxin, or they already have greater than 1 millimeter of ST segment depression, or they have a pacemaker. I just rattled all that off. That whole long list are people who commonly the stress test is not going to be chosen for them. Instead, we do something called perfusion imaging. We'll talk about that. It's also, perfusion imaging could be done if someone is unable to get their heart rate or their systolic blood pressure elevated for different reasons, different kind of autonomic neuropathy that goes on, and their heart rate's not going up and their blood pressure's not going up. Exercise testing is not going to mimic result. We're not going to get data from that test. That's why. Or patients that are much higher risk, symptomatic, they're really active in the disease and they're symptomatic. Those who have a multiple history of open heart bypass surgery. Those who are referred to an echo exam but have poor quality echoes. We'll talk about what the echo is. Inappropriate would be someone who just simply has contraindication. So they're actively and having a heart attack, really elevated angina. Anyways, myocardial perfusion imaging is something else that's important to kind of look at. So this here is showing you an image, right, that's showing you the differences in the left ventricle wall. So it's showing you the size difference between systole and diastole. So here in A, if you can see my cursor moving, right, this is end diastole at rest. Here is end diastole at rest, right? So we kind of low systole at rest. So relaxation, contraction. Down on the bottom, this is during exercise, right? So diastole during exercise, and this is systole during exercise. So kind of showing you those differences between them. When we talk about an echo is an ultrasound of the heart, and there are people who go to school. Oftentimes, you find echo imaging done in a lot of community colleges. It's really a great profession to become an echo tech. An echo is an ultrasound of the heart. It works just like an ultrasound that somebody would have if they were pregnant and they wanted to kind of see the gender of the baby, right? They put that ultrasound on the belly and you could see a baby in there. They use that similar transducer on the chest wall, and they can begin getting these echoes, these echocardiograms of the heart moving. So it's going to be able to show a really good view of the motility of the heart, so how well that wall is moving. It is really good at looking at ejection fraction. So ejection fraction is the force of the blood coming out of the ventricle into systemic circulation. It can look at how big that wall is of the left ventricle. So echo are commonly done, they're commonly used. It improves significantly in being able to uncover information when someone has ischemic heart disease. So when we think someone has ischemic heart disease, remember the word ischemic is lack of blood flow. So they got a blockage in there, they're not getting the blood flow they want, they're probably angina, shortness of breath. So instead of just doing a standard stress test, we can combine it with an echocardiogram. And we can do what we call a stress echo. So it's you and I, one of us running the treadmill, and then you have an echo technician in the room with you running the echo machine. And now we can take a look at perfusion imaging. So this is showing us, which we didn't need to read this, I'm not going to ask ask you questions on this, but it just shows you areas where perfusion, where the blood where the blood is not being uptake during rest. So showing you what it should be with heart disease, right, ischemia, versus what it is in a healthy heart. So to have an echo, right, these are usually people who you can't run a stress test on them because they have underlying heart stuff, right, the bundle branch block, the ST elevation, right, they have other reasons. The other problem is that we know that some stress tests produce what we call a false positive. So if someone has a false positive, we don't know that. So a lot of times it's going to be good to follow it up with an echocardiogram to ensure all of that. So again, who is inappropriate, multiple myocardial infarctions, complex wall abnormalities, someone who's obese or COPD, inadequate ambulation, they can't get on the treadmill and walk. So an echocardiogram, right, they're going to walk on the treadmill and have an echo at the same time. If they can't walk, then we're going to do something called a pharmacological stress test. We'll get to that near the end. So basic stress test with an echo, and as on the slide, what we call a pharmacological stress test testing as well. So let me go back. So with a stress echo, they're on the treadmill doing our EKGs up and every 3 minutes, blood pressure, heart rate, your classic stress test. But the echo comes in at baseline. So you lie them supine on the table right beside the treadmill. You do an echo at rest. We exercise them to their peak max, hopefully 85% or higher, until they just can't go anymore. We call that a symptom-limited stress test. And then we literally throw them on the table and get another echo at peak. So their heart is racing and pumping really fast, and you throw them on the table beside the treadmill, and the echo tech is going to do that echo. So that's the echo tech. It's really the stress echo. It gives you all the cardiovascular information you need from the EKG, and it's going to give you those images from the echo. Something a little different is called myocardial perfusion imaging, and this is when we can use thallium. So you stress them on the treadmill, and so we would stress them, and then a nurse would inject them with some thallium. And then at the thallium stress test, you can compare how much uptake of oxygen, how reactive the tissue was. So a thallium, right, walk on the treadmill and have thallium injected so we can look at the perfusion. So the follow-up to normal resting EKG patients, taken digitalis, women, someone who has documented heart disease. Another thing we want to look at is a cardiac catheterization, right? I love these photos. I think they're always so interesting, but this is a black and white of an angiogram. Right? So an angiogram happens in a cardiac cath lab. The person's lying on a table. They're usually awake and conscious, and the doctor is going to get access either through the femoral or in through the arm, get a wire up there, inject some dye, radioactive dye, and take some x-rays. So what are you looking at right now? This first arrow, this line is very thin in the middle, right? It's very, very thin. So what's happening is this is the left anterior descending. That's the artery that goes all the way down the front, left of the heart. There's a blockage inside there, arteriosclerosis, plaque, and what they've gone in during the heart catheterization is they put a balloon, and the balloon opens it up, and then they leave a stent in there. And then you compare, look at how nice and wide that is. So in this area, it's lack of blood flow. This whole area of the heart is probably symptomatic. Angina, shortness of breath, fatigue, not feeling good, they're not getting the blood flow that they need. On the flip side over here, now you're getting adequate blood flow going on. Okay. Angiograms are fabulous because they can fix them, usually right in there on the table. You get data right away again, but we need to make sure, the physician needs to make sure they follow that decision tree. So appropriate versus inappropriate, high risk based on initial we know they're high risk, we know they're kind of an active ischemic heart disease, unstable angina, non-elevated ST-MI. A non-ST elevated MI is a little confusing because we haven't really talked about the EKGs, but these three things, I guess, I'm trying to tell you. is the appropriate reasons why you would have an angiogram is that they are really certain you're perfect, this client, this patient is a perfect example that they definitely are in active heart disease, they've got high risk factors, they're having really unstable angina. There's evident that there's stuff going on in there. So they can take the cath, get in there, inject the radioactive dye, take a look at where the blockages are, and act right away. They can either go ahead and do the revascularization, the angioplasty and stent, or make other plans later. Obviously, if somebody is low risk, they're not allowed to just throw them in the cath lab. It's very, very expensive. It's also a higher risk. So a candidate for non-invasive testing, oftentimes I want to start them just with a stress test and see if they pass or fail the stress test. Stress test is a few $100s versus an angiography, thousands and thousands of dollars. So definitely a big difference on cost. So when you're looking at the coronary angiogram, cardiac catheterization, again, it's gold standard. It gives us so much good data. Cannot determine ischemia during the stress test. So the stress test doesn't do its job at giving us the data that they wanted. So after a stress test, they could order the angiogram. Or they could skip the stress test altogether and just go straight to the angiogram. Usually it's looking at lesions, blockages, atherosclerotic plaque, greater than 70%. That's usually what begins to make symptoms. So ischemia usually sets in. When someone starts complaining physically of problems, we know, you're going to remember, that's a sign that usually the blockage is pretty blocked, so it would be 70% or greater. They find that when it's less than 70%, we don't usually get a lot of symptoms, so that's when you want to look at more preventative medicine, blood pressure, heart rate, all of those things. So again, think about how powerful that is, that statement I just said. If somebody is complaining of angina, fatigue, not feeling well, there's a good chance that inside their heart they're already having some occlusion, and that is what's giving them the ischemic symptoms. This is a great looking photo. This is showing you intravascular ultrasound image. This is showing the doctor how clear or how blocked the lumen is, if there's a lot of plaque in that lumen or not. Obviously, if there's a lot of plaque, it's going to become more narrow and obviously restrict blood flow and cause a lot of problems. Something else is called calcium scoring testing. And appropriate for people that are asymptomatic, but we know have a high risk for heart disease. So remember, we want to make sure you know your risk factors: diabetes, obesity, blood pressure, systolic, diastolic, cholesterol, right, LDL, HDL. Inappropriate for people that have already known established disease, patients younger than 40 or patients older than 75, so that kind of wiggle room. The intravascular ultrasound I just showed you on that slide earlier, right? So intravascular ultrasound was this nice photo, and again, that's showing you the lesions that are in there. It's going to help the physician determine where the blockage is and how they want to treat that. Oftentimes, in its second bullet, it says evaluate vessel patency and stent operation. So they can go inside and take a look at, is the stent holding open that blockage? Is it doing a good job? How strong is the vessel? Do they need to go in and reballoon and restent that? Again, this is another, obviously we're not in a class to learn all about perfusion of a heart, but this is looking at how effective uptake is. So again, these perfusion images, I'm not going to test you on those, I just want you to know that they exist. Now, many times they're in the coronary cath lab and they see the lesions and they've got to make two decisions. Go in with the balloon and the stent, fix it right then and there, or go give them open heart surgery. Let's first talk about the balloon and the stent. So this is what we call a non-surgical procedure. The balloon is going to be put right into where the blockage is. They inflate the balloon to squash that plaque to the side, and then, back in the day, that's all they would do is a balloon. And then they invented stents, and now the stents help more longevity. So the balloon would just inflate, push that plaque to the side of the wall. They would deflate the balloon and take it out and hope it would last. As technology advanced, now they're able to inflate the balloon and deploy a stent. So the stent is like a little metal fence. It's about the size of your ballpoint pen, that little spring that's in your pen. And that little metal fence is inside the lumen, and it helps to hold that plaque to the side. most now that all of the stents are going to be covered in different types of medicine to really help them be more effective. Again, I'm going to skip my video links for these recordings, but I really would like you on the slides to go back and watch. There's some incredible things on YouTube that's really going to help you. So with the angioplasty, it could end up, it's a risk, right? They could go in there with the balloon and the stent and it could fail. Yes, the chance of death is there. It's low, between 1 to 4%. Usually with angioplasty and stent, people immediately feel better. I mean that instantly they're going to say, oh my gosh, oh, I feel better as soon as that stent is put in there. However, if complications happen, then that patient is going to be sent over to the operating room and have what we call CABG. You know, CABG is open heart surgery, right? That's when they go through the sternum and get access. It stands for coronary artery bypass graft. So most common complication can happen with an abrupt closure that they might need to go and have open heart surgery. So with angioplasty, this is a foreign subject going into the body, so they're going to do their best to really get the blood really thin. So aspirin, IV heparin, antiplatelets, inhibitors, hoping to minimize the cells that could get mad to that foreign object that's in the body. So blood thinners are really going to be common. If it's going to reblock or if we're going to have recurrent stenosis, it's usually going to happen pretty quickly. Within the first couple of months, usually is when it's going to happen. Here's another one of my great looking photos. I love these. So same kind of thing I showed you, which you don't really know what you're looking at, but these are the coronary arteries. Right here, you're not really too sure what you're looking at, but if you flip your eyes over to this artery, you see this is the same artery. This one is very light, and this one is nice and dark and getting blood flow. So here, the stent has been put in. So that is the big difference. Now this artery wraps around to the side, back of the heart. We call it the circumflex. The circumflex in this artery is blocked. They went in and put a stent in, and now there's adequate blood flow going in there. So just as it sounds, right? They put this guide wire in, and once it's right in the plaque, they inflate this little machine. It inflates the balloon as it's doing in the photo. The balloon pushes the plaque to the side, and then they can put that stent in. It is a very simple procedure. Again, the person's awake. It's usually just local anesthetic. They can go in through the arm of the brachial artery or in your inguinal growing, like in your growing, and through the femoral artery. That guide wire just, all of our arteries are all connected to the heart. They just get that wire up, and then once that is up into that occluded, blocked artery, they can go into the balloon and then to the stent, and then they just open that up and get that blood going through there. Again, I already had this slide, this is a repeat, but failed things could happen. Stents, now stents are coated in medicine, many different types of medicine, and antiplatelet thinners to help so we don't have as much abrupt closure with foreign substance. The stents are different lengths, made of different types of metal. I've had students who have wanted to go into cardiac sales, and a lot of times this is what they're selling. They're selling equipment that's used in the cath lab. So if you're interested, you can send me a little email, but there's a couple of, there's lots of great companies that are looking for people like you that have your fundamental understanding of anatomy and physiology, CVD, cardiovascular disease, where they need the liaison with all the new technology, innovative equipment in the cath lab with physicians. So, I say that because this, selling stents is really much needed, and it's a good, it is a really good job. Okay. What else? This is what they look like. I did my best to try to describe that to you, right? So the first photo is all that plaque is still there, and then they inflate the balloon, and then they put the stent in. The stent stays, and then the balloon comes out. If they're not a candidate for this, or that fails, right, meaning the stent and the balloon fails, open heart surgery is the next revascularization, so that is, getting access in there. CABG is how we nickname that, coronary artery bypass graft, is going to reestablish blood flow. It's very efficient at doing it. It is a very big operation to go under. Someone who is going to have open heart surgery are having active symptoms, right? Angina, whether it's stable or unstable. They have usually more than one location that has a blockage, so more than usually one artery. They may have also had a failed stent attempt, right? The stent in the wound didn't work. So for CABG, oh my God, I keep yawning. So for CABG, open heart surgery, it is very, very common. Hospitals nationwide do these every day, all day long. They saw through the sternum, open up, get access to that heart. They know what the blockages are because, of course, they've already had the angiogram, and they're going to go in and bypass, make new vessels to bypass the blockages. They can do this as noted on this slide, where they clamp the blood from the aorta so the heart stops and that blood gets rerouted, so your brain still gets the blood, but it gets rerouted to a giant machine, a heart-lung machine. And that heart is nice and still, so the surgeon can sew on those new bypasses, right, to bypass those blockages. Or they can do what we call an off pump, where the heart is still beating in his hand as he's sewing. So incredible. So lots of great YouTube videos on there to look at it. Most common is going to be the sternum, so they just take kind of like a handsaw, saw right through that bone, open up, get access. This is an important thing for you to know because as an exercise physiologist, we're helping them post-intervention. So we want to understand all of their aches and pains, right? What they talk about when they've lost all this upper body strength, or if their legs are sore because the saphenous vein was removed to make the bypass in their heart. The other photo you see is the side, that's a lateral. They would only really do the lateral, which is really nice if you can do one because the healing is nice and quick and it's not such a big procedure, but only if the blockage is right where it needs to be on the lateral side. Usually it's going to be right through the sternum. So anyways, the bypass surgery, literally new bypasses are sewn on the heart so that new blood is going through these nice clean arteries to make sure the heart's getting all the blood flow it needs. They can last forever, decades and decades, if they diet, exercise, sleep, rest. Otherwise, someone can end up after a year or two, end up having symptoms again and have to redo the whole procedure, which you don't want. What happens is usually about a month or two after CABG, people feel so good. They're getting so much more blood flow. They say, oh my gosh, I have not felt this good in decades. And they easily can slip back to old habits. McDonald's, smoking, sedentary, right? Meat and potatoes, like eating their old food. And all of a sudden now they have blocked up those new bypasses. So it's really important for you to know the patency of the graft is really going to depend, the patency of those vessels they put in, on the quality of intervention we do when we're in therapy with them. The slide is showing you the different access points of where the surgeon can get the vessel. Most commonly, it's going to be the saphenous vein in the leg, so either the growing to the knee or the knee down to the ankle. They can just remove. It's a big, long vein. It's a really actually big vein. It's like this, I don't know, the size of a straw, maybe not quite as big as a straw, but it's big. And they're going to turn that vein from the leg into an artery up here in the chest. The other one that's really common are these mammary arteries. So we've got the subclavian that runs right by our clavicle, and off of it, right now in all of us, we have these arteries, the left and right mammary artery just going to our chest wall. The surgeon would go in, detach it, cauterize it from the chest wall, so it's still connected up this way, and now they're going to sew those onto the bypass. The blood is going to go straight into the heart through the mammary arteries, which is a lot to try to visualize if this is all new to you, but this is a photo of what we call an open heart surgery, a bypass graft. On this photo, I see 3 bypasses, right? So I don't know if you see them, but the 3, we've got 1, 2, and this one is 3. So let's start with this one. This is a saphenous vein. I can tell it's a saphenous vein because this is the aorta. They poked a hole in the aorta, kind of like a little hole puncher, and then they sew, the word is anastomose, one end of that vessel. This vessel is a saphenous vein from his leg. So they're turning a vein into an artery, pretty much. So they sew it on to the aorta. So now the blood's going to go through the aorta, and it's going to go in through the saphenous vein. Through the saphenous vein, it's going to bypass the blockage, is going to get to whatever area of the heart it needs. So it's a literal bypass. These other 2 are the mammary arteries I told you about. So here's our subclavian. This would usually just be attached to the chest wall. They detach it and they sew it onto the heart. So now the blood is going to go through that subclavian all the way down this mammary artery and down to the end of the heart. That's what an open heart surgery is. New bypasses put on to help blood get to where it needs to be. Moving on. Another thing is called a PET scan, a PET scan. Again, I've given you a nice link. It's kind of tiny on that slide, but this is another very innovative piece of technology, right? A non-invasive, highly accurate, identifying the severity of heart disease. So they can do it at rest, and then with pharmacological vasodilation, what that means is they inject medicine into the heart then starts beating, right? That's the pharmacological vasodilation. So the person's lying on the bed, they don't feel good because you're lying on your heart, it's pretending that it's exercising, right? That's what the medicine does. But then what's happening, that the PET scan is scanning and getting where are you at rest, where are you during pretend exercise, right? The medicine that's injected, and being able to assess and look at the differences between what's going on. So here are those images. Again, you wouldn't need to have to read any of this, but it's helping to show areas of where we're not getting blood flow. So we don't do these tests, but I share this because this is something that you could see done. Patients ask about testing. So the same, right? The MRI testing is being able to look at what areas of the heart have been affected. Oftentimes we use these MRI testing, right? This kind of cardiac MRI testing with cardiomyopathy to be able to visualize what's going on with the structure of the heart, what kind of damage could be done. Again, another example, the only thing I want you to know is the stress testing, the stenting, the open heart surgery, the ischemia, like all of those big ones. These are all extras, language that could come up in a clinic. Calcium scoring is a non-invasive. It's what happens using an electron beam, so an EBCT, and it's going to help to interpret the calcium scoring. So pretty effective at looking at what kind of damage is happening in the heart, what kind of atherosclerosis is in there. This is an interesting one. This is the story of a fellow. You can click on this one, the TWA, the T-Alterons testing. This is screening and risk stratifying individuals for risk of sudden death, like risk of just dying, right? So this is capable of assessing patients that have had previous episodes, take a look at what is the probability for future things. It's very interesting. So if you've never heard of this, you can kind of click on my link and kind of see the fellow's story about this. So what do I want you to know in this assignment? In this collection of slides, we are looking at assessment. We are looking at what's going on in a stress test, a GXT versus a CPX, right? Take a look at Bruce protocol. Take a look at, right, absolute versus relative contraindications. All the information we're going to get out of a stress test. So I want you to be able to, right now, be able to go back through these slides, and I want you to make one question. You're going to type up a question. So it doesn't matter really what you want the question on. It could be true, false, it can be multiple choice. You're going to put it into the discussion thread. So, you write your name, right? So John Smith, and he's going to do a true, false, or multiple choice. Don't tell me the answer. Post it on Wednesday. Everyone else is going to reply what they think the answer is. The end of the week, we're going to come back and see where we're at. So this is going to really try to get you to go back and look at the slides, and you're all making one test question. That's it.